everyone. We have a very special guest with us here today, Kaakpema Yelpaala, who goes by KP, and who is the director of InnovateHealth Yale, the faculty director and senior fellow and lecturer here at Yale. KP founded several companies, which we'll talk about today, including Access Health Mobile in Africa and InnovateHealth in the US. And what we're really going to talk about today is just that wild journey and all the ups and downs.
Right.
You spoke to my class twice today, and I learned something new different each time. And so the themes I was thinking about debriefing with you on in the podcast are really those different settings that you worked on. So You started off out of public health school working in foundations and nonprofits like the Clinton Health Access Initiative.
Right.
And then you decided to just start a business doing health tech, going from non-digital to digital work in Africa. So I wanted you to just reflect on similarities, differences, strengths and weaknesses in those two different sectors in Africa, the nonprofit versus for-profit sector, in the context of our shared mission of health equity.
Of health equity, right. Well, thank you so much for that. And this is really fun for me to be able to talk about all these different parts of my experience.
It's like processing.
Yeah, it's like maybe therapy.
Yeah, it's healing, right?
It's healing.
In class, when one of my students asked you to talk about one of your companies and what it was like to shut it down, and you were like, it was trauma. I was thinking, well, I hope this is healing.
Yeah, no. So I like to say, like, people now, when they see my background, they see that I've done a lot in digital health. But I really like the chance to share my early story, which is I didn't start as a technologist, right? I started
old school public
health and about outcomes and vulnerable populations and ensuring that everybody has access to quality care, to public health interventions. And so that's what led me into your more traditional nonprofit, route. Like I did global health was my track at the Yale School of Public Health. And so, we were trained to think about working with ministries of health, working with the World Health Organization, thinking about things in that way. And so, my first projects were in Ghana, the country of origin where my family's from. I was born in the US and
your dad was born and raised in a mud hut?
Yeah, my dad was born and raised in northern Ghana near the Burkina Faso border in a mud hut. So came from a very rural, poor background. I was really fortunate that they identified him as someone that had a lot of academic potential, even though he was in that setting, and he was able to find a way out through education. And so for me, that becomes part of my mission. Because, when I look at that, I could have easily been that person if my dad wasn't so lucky as to come out of those circumstances. My mom also comes from a low-income family in Ghana. Like I could very easily be in a different place. And to think about all the opportunities I've been able to have and potential, I think about all the other people that have the type of potential that I have that are unseen and don't have the opportunity. And that kind of drives my broader mission. And so that's just taken the shape of public health and well-being. And so, it put me in a very nonprofit mindset. Let me go out into community. Let me work with governments. And we did really interesting work. And stuff I was proud of. And again, very grassroots. When I worked with the Clinton Foundation, I actually got an internship with them after my first year at Yale, and it turned into a job. It was different because instead of me being like a young public health student with a nonprofit in Ghana, now I'm working in this big organization founded by a former president. And so the scale and scope of what we were doing with the Clinton Health Access Initiative around HIV treatment was completely different from anything I'd ever done before. And it was in East Africa. As a kid with Ghanaian parents, I honestly knew nothing about East Africa.
Yeah, West Africa and East Africa are
They're completely different worlds, right? And the first place I went to work was in Tanzania. So I get to Dar es Salaam, and it was just completely foreign. Everyone's speaking Swahili, But what was interesting is that if I just look at my two nonprofit experiences between Ghana and then working for Clinton Foundation, the scale was the big differentiator. The nonprofit that I was working on in Ghana that I founded doing public health work was very small scale. Small foundations, family and friends would donate. We had a very modest office. We were doing really small but impactful programs. But it was the work, right? And I had fun. I was in Ghana and I was kind of engaging with the culture and seeing family. But now with Clinton Foundation, the mandate was very different. How do we increase access to HIV treatment for a couple million people. I actually think at the time that we started our work in Clinton Foundation, I'm going to age myself, it was 2004. And I'm going to throw some numbers, people can fact check them, but I'm just going to guess. I think I'm in the magnitude. At that time, we thought that 2 million people were HIV positive in Tanzania in this period in 2004. We thought that around 400,000 of them needed HIV treatment immediately. Like they needed access to antiretroviral drugs. So 2 million infected, 400,000-ish needed HIV treatment, ARVs immediately. But in the numbers, next to nobody was on ARVs. So the question was,
how do you get from 0 to those numbers?
Correct. And it was a 5-year plan. So what the Clinton Foundation did is we worked, President Clinton's view at the time is that he used to say it this way, for better or worse, if all donors and all foundations left Tanzania tomorrow, what would be left is the Ministry of Health. So he felt it was very important to work with and through the public sector for sustainability. And so the programs were owned by the ministry, but then Clinton Foundation was coming in as a supporting function to build the capacity of the government to be able to serve the people. And so at that time, we developed what we called 5-year plans. So it was supposed to be bold and ambitious. So we were going to develop a 5-year plan to get everybody inside of the care and treatment continuum that needed to be. Everybody. From zero to everybody in 5 years.
Wow.
And people thought the Clinton Foundation folks were crazy. All the USAID workers and others are like, these people are coming in and don't know anything about, they don't know anything about, they don't know anything about how things work, but that was the mindset. So again, you could see, I think that was the biggest difference is getting thrust into that frame of thinking after having done much more like, let's just say modest, small scale nonprofit work early in my career.
And so what made you decide to then shift into building digital health businesses in that same setting? What was your thinking? The
thinking process. So a couple things. So one, what I saw doing the work with Clinton Foundation is that we did do some great things. We pushed the envelope. And we pushed the envelope on the basis of people dying unnecessarily from HIV and AIDS. So it was we saw it as a moral imperative for speed, right? And so I learned a lot about just how ministries of health work, how to mobilize resourcing, all the things that don't work, working at that scale with ministries and nonprofits and where you find friction. But also something else happened. When I was traveling the field all over East Africa, this is when there was a telecom boom. And so everybody was having access to a basic mobile phone and able to text even in the most remote areas. So while I was doing all this other work, I had this observation. I was like, well, what if we could use the power of text messaging and technology to better connect patients and providers in remote areas? And
so it was the opportunity.
So it was the opportunity I saw with the digital infrastructure because I was living there. I was traveling to the field all the time. I was in Rwanda and Uganda and Tanzania, and I was in the car for 5 hours. And I started to realize like, oh, my phone works, right? Like, and I could be in the most remote area. And that was the seed of how I was like, what if I tip my hat into this emerging digital health theme? Back then it was called mHealth. You'll remember.
Right, I do remember.
That was the term of art.
I kind of didn't notice that that stopped being the term.
Because now people like to say digital health, but really it was mobile health. mHealth was the term of art.
And it wasn't. I don't think it was you that decided that this should be a for-profit route. I think that the whole mHealth space was just kind of a for-profit space.
Yeah, it was. There were a handful of nonprofit organizations that were trying to develop open source technologies around this. And then there were a lot of people that wanted to bring, because basically the emphasis on starting a for-profit when I made this transition was about sustainability. So we always talk about sustainability when we think about health equity. And the question is, what model or models or mix of models can get us there? And I think when I worked in nonprofits, I saw a lot of opportunity for impact, but I saw a lot of challenges with sustainability because you have foundations and foreign aid and all these outside agencies funding domestic.
The second their agenda changes.
Correct. Then all of a sudden funding.
Budget changes, it's over.
It's over, right? And that's exactly what I was seeing. And I was seeing what that meant, when you had a program that was successful Then all of a sudden a donor decides not to fund it anymore, and then it just goes away. And then everybody's chasing the new thing that the donors decided.
Yeah.
And I found that very frustrating. And so I said, what if we used a private sector market-driven model?
Then it's less donor dependent.
Then it's less donor. Yeah, exactly. So that was the experiment. Could I do that?
Okay.
Yeah.
And so what were some of the similarities and differences that you saw operating in those two spaces in Africa, the for-profit and nonprofit space? In terms of your ability to, in terms of what was broken, there's something broken in each.
Right.
And also in terms of your ability to reach your goal of improving outcomes and equity.
Right. So what I liked about the for-profit side is that I was able to generate some resources. Like I got an early customer, as we talked about in the class, in Uganda. That kind of helped me get started. Then I raised a little bit of money from friends and family. So what that allowed me to do is to go into the market and just ask people what they wanted and what they needed, right? Because oftentimes if you get funding from a foundation or a grant, it depends. In an academic setting, you might be pursuing a question, right? And you have funding to pursue a certain type of question or issue. In the NGO space for programs, oftentimes the donors set the agenda, right? So you find yourself kind of being led by what the funder's interest is, and then you're trying to align the funder interest with the community the best you can as like that broker. And there's always a misalignment of some kind. And what I like with the company when I raised a little bit of money and I had these first clients is I could just go to the market and I could meet with clinics, leaders, and I could just be like, what do you need? Like, what would you pay for? Like, so that I felt like there was a more direct connection to what people wanted. And because I had investment dollars, I could choose. I wasn't forced by some other donor telling me, at least at the early point. Obviously, I had investors who were expecting financial returns, but in the early phases, I had a lot more flexibility to be creative and engage the market. I'm like, what do you actually want?
Okay, so I'm going to dig deep in two different places. And I think it's because I've been hanging out with Yale students too long. Like they ask these tough questions.
Okay.
So the first one is it's more of an observation. Like even in Uganda, your first customer was USAID. It was a multilateral organization, I think, if I understood correctly.
Well, yeah, we were subcontracting. The technicality is we were subcontracting with a group that was funded by USAID. So it was like kind of indirect. It wasn't like direct to US, but it was like that. It was resourcing.
It just feels like everything is so deeply entrenched. Like even when you're trying to operate an independent for-profit business, like the multilateral agencies are still there trying to operate in that space.
Right.
So it's still kind of like their agenda is still there. It's hard to escape them.
It's very hard to escape the agenda, exactly. But the thing is, I wasn't fully reliant on that money, right?
Yeah.
So it's one thing if...
It's different if they're a customer.
It's different if that was my only source of capital.
Yeah.
But it was basically like revenue to help offset costs or investment to learn the market.
Right.
So that's what makes it a little different. If I was just a USAID subcontractor and those were the only resources I had, then I'm kind of starting to fall into their priorities. But to me, it was opportunistic.
Yeah.
I happen to have alignment. So I was able to have a little bit of money.
A bit more freedom to have your own agenda.
Yeah. And then by raising money from family and friends, I had freedom to pursue in the early days, like the market and understand without that, like having a foundation tell me this is what you have to do or
And then the other nuance in terms of like having a plot twist in the wild journey of the international health entrepreneur is that when you were growing the for-profit business, after you did the proof of concept in Uganda and everything, you got venture capital money from the US because at the time, 10 years ago, there was no venture capital firms there, right?
Exactly.
In Africa. And so then they also, because they were on your board and they were decision makers, at the end of the day, basically told you to shut it down because it wasn't profitable enough, right?
Right.
And they wanted you to try it out in the US market.
Right. So the only catch that I would say is that my investors were also Africans. So that's the difference. So the luck I had is that when we say my investors are from the US, I don't want to infer that my investors didn't understand the market. I actually found investors of Liberian descent who were business leaders in the US. and wanted to invest in Africa. So actually my board and investors were very knowledgeable of the African markets and had aligned incentives because they were also people like me of the diaspora. And I think it's very different from if I had an investor that didn't have a personal connection to the continent or knowledge of the continent. And that's why I was actually lucky, right? But then at the end of the day, having the for-profit motive, if you can't, and having venture capital, and I would say my investors would have said they were patient capital, which I think they were.
That's true. They weren't sharks.
They weren't sharks.
Yeah, they were impact investors.
But at the same time, we needed financial returns that we weren't able to achieve in the model at the time.
Yes.
Yeah. And
that is the third nuance, to be honest. Like for-profit and venture capital are two different things.
They're two different things.
You can start a for-profit SME, small or medium enterprise, fund yourself through revenue bootstrap.
And organically
not
grow.
Take funders and still exist as a successful business making revenue, but it wouldn't be that high level revenue.
Yeah, it wouldn't be that high level growth. And honestly, a lot more health equity innovators that I talk to are going that route.
Really?
And some of them actually, when they look for advice from me, what I've come to learn, I mean, I wanted to experiment with venture capital, but I came to the observation you've mentioned, which is not all businesses need to be venture capital growth businesses. And you might be able to build an equity-centric model that is profitable and grows organically without the need for having to secure a lot of external capital. And so you can also own your work more, right? You're not beholden to investors the same way. And I think a lot more like health equity innovators now, and where I'm kind of pivoting, but in the US, and some are thinking about this more.
You don't hear that kind of advice very often. I'm sure our listeners would be really grateful to hear that. Just like that unique point of view, because everyone's chasing venture capital.
Right.
So then your investors saw the opportunity of, hey, wait, right here in the US, we also have underserved populations where there's this digital divide between what providers offer and what they're able to receive.
Exactly.
And so they wanted you to test out the model you were employing in Africa, right here in the US. Tell us a little bit about that.
Exactly. So what was our offering? So in terms of what the product was on the African side, the African market was primarily paper-based, as we talked about in class. And so there was a push to help clinics and hospitals, we just use the term digitally transform. So get all their records into an electronic format, be able to use tools like texting and other things to communicate with people in an interactive way.
We're not that far ahead in the US.
It's true, right? And that's what we were trying to do. And that was the software we sold, and we got lots of users on it. And so what we found is in the US, low-income populations, like Spanish first speakers, multicultural, you don't find them in the patient portal. So the patient portal with health reform during the Obama administration had a meaningful use clause, which is really trying to get people to adopt the electronic health record. The catch is you need an email address, you have to log in, all these things. When we think about vulnerable populations, low-income folks, many of them don't have email addresses, they find it inconvenient, they prefer to text or use WhatsApp, and they're culturally diverse. And this is very much the same type of user persona, if I can put it that way, that we had in sub-Saharan Africa.
Right, because you were serving the rising middle class.
The rising middle class with a lot of cultural diversity. They preferred texting. They weren't going to go in a patient portal. That wasn't the thing. And so my investors said, maybe you've got an idea that is just in the wrong market environment. Let's try this out. And it actually got traction. Our first client was Adventist Health White Memorial in East Los Angeles. We worked with an initiative that was serving about 50,000 Spanish first speakers that were what we call covered lives. So there was a payer that was paying White Memorial to take care of these people.
Like value-based care.
Basically. And so our job was to develop communication protocols in Spanish and English where relevant that were personalized to help them know that White Memorial is a place they could seek care and to get them directed to the right services. And it worked quite well. We had that client for the life of the company.
And so then I'll ask you a similar question. What similarities and differences did you see in these two settings of serving the African middle class patients versus the U.S., in this case, Spanish first speaking communities in Los Angeles?
Right, where we started, and then we started
also with the providers.
And with
they're very different providers.
They're very different, So on the surface, people would say, this sounds strange. These seem like completely different environments. I don't understand how he's going from this place to that. It doesn't make sense. But what I got to learn is, I'll use a term that we use in healthcare, and I think people listening to this would understand, but the African healthcare market from a private sector perspective. So again, we're talking about private hospitals where people pay to access care. It's what we call a fee-for-service market. So there's not wide coverage with health insurance. So on the public sector side, ministries of health and governments have these national health insurance schemes, which are supposed to make it free or very low cost for people to seek care. However, that's for government facilities. And it's not a popular thing to say, but I like to sometimes say, for all the millions and then billions of dollars that have gone into the public health sector, if you went to the average African anywhere, they're not going to tell you they would choose to go to one of those facilities.
Yeah,
and so then
many low and middle income countries.
Yeah, so then
Asia.
Right, so then people would say, I'd rather wait and die at home than go to, and that's the public.
I was literally told that in a South Asian context when someone told me, like, when you go to the public hospital, it's a last resort. Like, you go there to die. Right.
So there's a national health insurance cover, but that gives people access to public sector facilities they do not want to go to. So what's the alternative? Private hospitals and clinics. But now in the US, we have employer-based insurance for a lot of people. And then we have other safety net programs for insurance. But in African countries, there's no widespread private insurance. So then when you go, it's only the money you have that determines what care you can get, right? And so in that fee-for-service context, people aren't driven by quality of outcomes, but by generating money, right? I want to either retain my patients or get new patients because that's the lifeblood.
Yeah.
So then there's no incentive for quality. This is actually the big conundrum of the U.S. healthcare system, and we all experience.
Just as an aside, before we shift back to the U.S.,
Great.
Because I kind of feel bad opening that can of worms and not closing it. There are some social entrepreneurs in the global South who are working on this exact problem.
Of course, yes.
Of like, let's provide high quality care with the goal of making it low cost.
Correct.
So that we're not. But that is this whole other can of worms of like, are we building parallel systems versus investing in the existing systems? But that's a topic for another episode.
Right. And I think that's right to acknowledge, like, that's an opportunity that innovators are going after, which is, can they offer low cost, high quality care to fulfill this gap? So,
and can they do it in a way that like strengthens and connects with the existing system?
Correct. And it's a really challenging feat.
It is really challenging.
But people are out there doing it. I appreciate you flagging that. So I don't want to
go on a tangent.
Yeah, I don't want to disacknowledge that. But in the fee-for-service context, like, and people will know this is true, that live in these contexts, like, is what you can pay determines what care you can get.
Absolutely.
And really
in the U.S.
and exactly. And that became the commonality that I realized, which is in the U.S. in a fee-for-service setting,
we don't have these.
We're not driven by we're not driven by outcomes, right? Like, and so that's why in the U.S. we use the term value-based care as a term to start to talk about aligning financial incentives with health outcomes, because we know in a fee-for-service setting, basically you're driven to get more patients, and physicians don't feel empowered. They feel like they're told you have to see so many patients a day. They don't feel like they can spend time with patients and really get to know what they need. And so it's also leading to burnout for a lot of physicians, right? So that actually, those two dynamics are very similar between the private health sector in African countries and the U.S. healthcare challenges. Yeah.
That's not something I would expect, but you're right that it is very similar in terms of the incentives not being aligned with improved health outcomes.
Right. And I think we talked about in the class, the other observation I had is that when we talk about value-based care in the U.S., we talk about aligning financial outcomes or financial incentives and outcomes. I look at foreign aid in African countries for global health a little bit like that. But the payer isn't an indigenous or local agency. It's a foreign one.
Yeah.
But USAID or Gates Foundation will basically pay you on the basis of driving certain types of outcomes. So when you really think about it, they're like a value-based payer, because they say, hey, I'm going to fund you to reduce malaria burden here. I'm going to fund you to deal with TB there, right? And so the money is tied to outcome, but they're a foreign entity working on behalf of these local problems, which creates its own distortion.
And then it also goes back to the question of like, to what degree do we want to invest in the Ministry of Health versus in private providers?
Correct. And issues of sovereignty. And
And we talk about that so much in this course, like how innovators can lead to systems change, which kind of leads to the third area I wanted to talk to you about. So we talked about similarities and differences between for-profit and nonprofit in Africa, and then between the African context and the US context. And we've been talking about like direct service versus systems change. And I know that now you're focusing a lot these days in various roles in Colorado, where you chair the
eHealth Commission,
and with the American Medical Association,
right?
Where you're on the
Equity and Innovation, board.
And so you're thinking about policy issues these days. And so I just wanted to ask you to tell us a little bit about that and how it fits in with the roller coaster ride you went on in trying to start these companies for health equity, for outcomes and access.
Right.
What are the policies you're working on that can support innovators trying to do that work?
Right. So I really feel like, as I did this work, and one, I feel really proud of what my teams have done over the years. I feel really fortunate to have had the investors I had and the people and institutions that came along the journey, because without them being willing to invest in me and the teams, I couldn't have had these experiences and learned these things that I've learned. And I think they were also willing to go on the journey of trying to experiment, to find like new models. And so I think like my observation is that you have to have an enabling environment for innovation that supports health equity. Because that's where this all started for me, is really thinking about vulnerable populations, thinking about the fact that, my parents are immigrants to the US from Ghana. My dad grew up as a rural, poor person near the Burkina Faso border, and like thinking about how much what I see as latent potential is out there in the world that we never get to see shine, right? So to me, that's been my mission. And so when I think about health equity and innovation, it's the policy environment, it's the funding environment which creates this incentives within which innovators can operate. Every now and then we have some innovation that comes that changes how the world works. It's very rare, right? And I think it's hard to predict sometimes what those things will be. And I think we could list plenty of things we see in the world that have just changed the dynamics of how we interact. But I really feel like you have to, for the type of change I would like to see, we have to, one, focus on how to better align financial payment and outcomes, right? Because again, like in a fee-for-service setting, if your only goal is to make money, then our system works as it does, right? To the detriment of so many people. So that's like a policy question. And there's lots of really smart people trying to figure this out. And in the US, they say 50 states, 50 health systems, right? It's like, there's so much diversity, but there's organizations like City Block and others that are starting to crack the code little by little in like how we bring these value-based models to scale. So that's why, because policy enables that. But then also when we think about inclusion and diversity, like, if only certain types of people have the opportunity to innovate, it's pretty clear why a lot of the innovations we have don't serve everybody. We need people with varied lived experience. So I'm working with some friends on a venture diversity reporting bill that started to get some traction in the US and bring it to other states. So California just launched this bill last year, late last year. And now states like Massachusetts and New York are, and even in Colorado, we're going to look at it. But the idea is to mandate that venture capital firms have to disclose the diversity metrics of their portfolio, right? So we can start to really see what that looks like. And then people can really start to consider how we invest in a more diverse cadre of innovators. And it's the same in an international setting. There's something that was going around a couple years ago that was showing that if you look at the faces of all the unicorn companies, so companies that have reached $1 billion or more across Africa, the faces of the founders are primarily white and East Asian. There's almost no indigenous Africans that are on that. So basically, we've got a lot of expatriates that are coming into Africa, they're able to raise money through their networks and whatever wealth they can access. And they're actually generating wealth on the continent, but they're from the outside. And so these are the things that we have to improve, whether it's the US or we need more representation as well.
You know, it's interesting, but the common thread across these three pillars we've talked about today in terms of nonprofit versus for-profit in Africa, US versus Africa, and profit versus startup, and policy. Versus startups.
Yeah.
The common thread I'm seeing is that where and how innovation happens and who gets to innovate is informed by where and how money flows.
Right, and the system.
And that's informed by policy.
Correct. That's informed by policy and other things. So as I started to think about it, me as one person can't solve these problems. And even if with these companies I founded that for different reasons, they kind of did their journey and I've had to move on, like even if I was wildly successful with them, unfortunately, it would still only be a drop in the bucket in terms of the problem. That's my bigger reflection. Like no one company that I founded, and even if it reached my wildest dreams of success, we'd still have billions of people that don't have what they need. And so that's where you start to think about systemic change and how we can be more catalytic for more people to take this on, because that's the only way this improves. It's not one person or one issue. It's actually how the system enables, because people are thinking about these problems day in, day out. I'm not the only one, right? But how do we create an environment where they have the opportunity to bring their ideas to fruition?
And where they're all talking to each other.
And where they're all talking to each other.
Innovation, and then innovation is geared towards strengthening these systems. Building parallel systems.
Right. Exactly.
So it all kind of fits in together. All the global players, all the different kinds of innovators, and the policymakers.
Exactly.
It is one big global system.
And the different modalities. So sometimes there's this pitting of for-profit and nonprofit models against each other. And I think for me, I've just been experimenting. You know, I did the nonprofit models. We had some impact. I also saw some challenges. So then I said, let me try a for-profit model. Then I did that. And I wasn't exactly pleased either there with so it's just, you know, I've just like any entrepreneur been experimenting. Mm-hmm. Yeah.
And I think that these experiences have been really important in informing how you're participating in policymaking.
Exactly. And feeling like I can advocate.
Yeah.
Yeah.
Exactly. Mm-hmm. Any closing words of wisdom you want to share with aspiring entrepreneurs innovating in the health equity space?
Oh, I mean, I think what I'd just like to say is I know it's hard. So I think the work is hard no matter how you're approaching it, if you're mission oriented. And so I just want to acknowledge that it's challenging, and that also like you need to consider your mental health and wellness because it's a marathon. And also like community matters, right? You need to find your community of other innovators and supporters and people that are going to be on that journey with you, because it's a daunting task. And it's even more daunting if you're thinking about doing it alone. It's not really going to be in your interest or the people you want to serve. So to be able to achieve persisting through the marathon, you need community, you need to think about your health and wellness. And you know, you need to understand you're going to learn as you go, and how we define success really matters, right? And sometimes things if we use external metrics of validation for success, sometimes they may not align with what our mission is, right? Like I started 2 different companies. They've done some great work. I didn't have like a huge exit and sell it for $1 billion, but I still think we were a success. I still honor the work that my teams did. I still feel proud of the people we reached, because I know that in that moment we were impacting them. And I think how you frame in your mind what success is and what progress is really important.
Sometimes success is that you tried and that you didn't just sit there and talk about everything that's wrong, but you saw a different way of doing things, and somebody's got to try it. And so many people have to fail at it before something
cracks through. Exactly.
Exactly. So I think success is being part of that movement.
Exactly.
You've been through a lot of ups and downs, and you're still here, and you're still
here, and I'm still smiling. I am still smiling. I still have gratitude.
Thanks for the work you're doing to shape policy and the work that you did in the trenches as an entrepreneur.
Thank you so much. It's been a wonderful conversation.
We appreciate you.
Likewise.